This meeting is being recorded.
Hello, everyone. Thanks for joining our new mini journal club. The idea of doing that over 15 minutes is just like to provide short overview of some recent important papers that will fit in our busy daily life. I'm so grateful to Dr. Heeger to accept to be the first speaker. Dr. Heeger is one of the legends of transplant. He recently moved from Mount Sinai to Cedar Sinai, Cedar Sinai, and he has been leading many CTOT studies. And today he will speak about the recent paper of the use of Infliximab induction in kidney transplant.
Great, thanks for the opportunity to be the first one. So I thought we would go through the results of this study, CTOT-19, about Infliximab and kidney transplant recipients. Paper is accepted and in press in JASN. It will be available officially, I think, in January, but if you want to see the preprint, you can find it on the JASN website. So we're going to talk about tumor necrosis factor, which is just a member of this family of cytokines that's listed here. It's one of many. And TNF can actually be bound to cells or can be found in the serum, and mostly we see it in the serum, and binds to a couple of receptors, most of which is focused on the inflammatory role of TNF binding to TNFR1, but there is, some cells have TNFR2, and that's controversial and as to what it actually does. So I think we could talk about that if we have time. Okay, so what does TNF do? Well, it's really an established pro-inflammatory mediator. Even though it's tumor necrosis factor, the fact that it was originally described as a molecule that kills tumor cells, it only does that under certain conditions, but it definitely is pro-inflammatory and causes all of these things, and occasionally can cause cell death as well. And in that context, there's interest in using TNF blockers to stop the pro-inflammatory effects in transplant, but there has been very little data. TNF blockade with etanercept is actually current sort of standard as part of the induction regimen for islet transplants because it keeps the islets alive for longer. There's occasional case reports of people using TNF blockade in kidney transplantation, but nothing formal and in large numbers. So we hypothesized that because TNF is produced following reperfusion of a deceased donor kidney, that blocking TNF alpha at the time of the transplant and we decided to use Infliximab for a reason I'll tell you in a minute, that will reduce post-transplant inflammation, and as a consequence, we might reduce delayed graft function, T-cell mediated rejection, DSA, chronic injury, etc. So we used Infliximab or Remicade, which is FDA approved for the treatment of rheumatoid arthritis and Crohn's. The goal of the study was to block TNF peri-transplant during that reperfusion and not prolong it, because that we were concerned that would have a prolonged effect. The Infliximab is really the only drug that can be given intravenously, and so we decided to do that in the operating room prior to reperfusion at the established dose, and the half-life is really a little over a week, so that by 5 weeks out, or 6 weeks, there's essentially none, ideally, left in the serum of the patients. So our study was a randomized, controlled, double-blinded study. We enrolled 225 patients who were transplanted, and they were evenly divided between the two study arms. So this is an RCT, deceased donor transplants, 13 US and 2 Canadian sites. These are the inclusion criteria, and basically it's deceased donor transplants with KDPIs in this range. They had to have a negative TB test because TNF blockade can increase the risk of TB. And then standard other criteria. So everybody was given our thymo induction, and then the experimental arm received Infliximab at 3 milligrams per kilogram, started prior to reperfusion. Maintenance was TAC, MMF, or MPA, and corticosteroids. And the control arm was exactly the same, except instead of Infliximab, the patients received a placebo sterile saline. So double-blinded. The only people who knew about what the drug was the pharmacy. And then the primary endpoint was the difference between the mean 24-month eGFR using a modified MDRD, and I'll show you how we did that in the 2 arms. We did not include histology as a 24-month endpoint, but we did go back and look at some of the elements of the iBox sort of post hoc. Okay, and then there are a bunch of secondary endpoints. So these are our patients. There were 113 and 112 in each arm. They're pretty standard and similar. I think, you know, this just shows you that African Americans were a little bit overrepresented, but not, you know, hugely. But we did have an active African American population. Okay, and then the donors, again, pretty standard in terms of what you would expect. We did have DCDs and deceased donor transplant donors. The KDPI range was here, but, you know, mean is in the 50s. Okay, so the first thing we really wanted to know is, did this drug work? And this is the TNF levels on day 7 and day 30. And notice that this in the treatment arm, it's much lower than the experimental arm, and it's hovering sort of between 1 and 3. So these are pretty low values, and significantly less. And we even see lower values at day 30. So this had an effect of significance, you know, 30 days out. Interestingly, when we looked at other inflammatory mediators in the serum, IL-1, IL-6, and IL-8, at day 7, there was a lower value of all 3 of them. So we which we didn't see at day 30. But at the first week, we've lowered post-inflammatory inflammatory mediators, suggesting this is kind of a cyclical inflammatory effect. So we were happy with that. Yet when we looked at the primary endpoint, and this is done using a linear mixed model, which includes all of the data, the individual data are shown behind the 2 lines. The red line is the Infliximab arm, and the blue line is the placebo arm. And you can see that, if anything, you know, the number for the Infliximab is a little bit lower than the placebo arm, but there's actually no statistical difference between the groups. There was no effect on eGFR. And this used all the data in the set to try to sort of account for trajectories and mixing data, missing input values, and all these other things. And it's a statistically valid approach, really nothing different. And if we try to divide this up and ask a number of questions, if we use different protocols for, or instead of MDRD using CKD-EPI or the race-independent CKD-EPI, no difference. And there's still a little bit lower in the Infliximab arm. If we only look at African Americans or older people or males or females, it doesn't matter. There's no difference in eGFR between the 2 groups. The primary endpoint showed that there was no difference. So we wanted to be sure that the immunosuppression wasn't different, and this just shows you the TAC levels totally overlap in both arms. No difference in the TAC levels, and there's no difference in the standard deviation of the TAC levels over time, meaning that there's no difference in a measure of adherence. So everybody was taking TAC similarly. The ATG, or the FIMO dose, was the same between the groups. And interestingly, if we look at the other things, the one thing that came up that was different, which is interesting actually, is in the Infliximab arm, there was statistically less MMF or MPA given over the first 12 months, and I'll come back to that. But otherwise, there was no difference in prednisone or other things. Okay. When we looked at secondary endpoints, none of them were different as well. So the duration of DGF didn't change, and whether we looked at primary non-function or slow function or the rate of creatinine decline, no matter how we tried to manipulate or look at these data, and these are all pre-established ways in the protocol, there was no difference between groups. We had no impact on delayed graft function. Now, interestingly, inflammation is much worse if you use a non-DCD donor. So if we pulled out the DC donors and redid the analysis, we got a hint of a signal, meaning that without the DCD donors, Infliximab looked like it might, if we had more power, have an impact on DGF, but it was not statistically significant in this group. Okay, there was no difference in the rejection rate between the 2 groups. TCMR. There was no difference in the number of individuals who developed DSA between the 2 groups. If anything, there was a few more DSAs in the Infliximab group, but this is not statistically different. And then the most important finding of this study was actually when we started looking at serious adverse events. And what was fascinating to me is that the BK viremia rate, shown in red here, was significantly higher in the patients who were taking infliximab versus control. And if the BK viremia that required a change in immunosuppression was higher in these individuals versus control, highly significant and different. And note, this is not a broad issue because the CMV viremia rates were not different. It was really just BK virus. And when we look at the timing of it, you can see that all of these BK viruses, so this is freedom from BK, so every time it goes down, they have a BK virus infection. It all happened sort of within the first year, which is, suggestive that it's strongly related to the infliximab. And note that the lower MMF MPA levels that I already reported in the infliximab arm were likely a consequence of this BK virus. People were dropping the MMF doses. When we actually looked at BK nephropathy, it didn't quite reach statistical significance, but higher numbers in the patients who got infliximab versus placebo, whether this was a central read or a local read or both. So it looks like there was a real signal there. So in the end, right, infliximab induction therapy, at least as how we gave it in this trial, doesn't benefit deceased donor kidney transplants over these two years that we followed them. But it did increase the rates of BK viremia, underscoring the complexities of targeting peri-transplant inflammation and inflammatory effectors as a strategy to improve kidney transplant outcomes. You need this cytokine. And I think one lesson here is that you really need this cytokine to prevent BK. And there's a couple of other suggestions that this is true. There's a couple of case reports of people who got kidney transplants and are on a BK inhibitor for, a TNF inhibitor for inflammatory bowel disease who got BK virus. And if you look at the patients, there are a couple of descriptive studies of IBD patients, inflammatory bowel disease patients, getting anti-TNF. And there's a real incidence in the native kidney of BK virus infection in those patients. Now, they didn't tie it directly to the drug, but that's kind of intriguing. So, I'll stop there. This was a multi-center trial with a lot of collaborators, and I just wanted to leave a couple minutes for questions, if you have any.
Great, thank you. That was great and on time. I got a question here. If you are designing the study again, or you want to do another study on infliximab, would you limit enrollments for patients who have long cold ischemia time, or patients who have maybe positive DSA or cross-match?
I would say that based on this study, I wouldn't do another study. And I think that the BK virus outcome was very concerning, and we're lucky it actually didn't affect the outcomes. If we took the BK virus and nephropathy patients out, it still didn't affect the eGFR. But I would be very worried about doing this again. I can't really argue that we should give more of the drug or give it for longer because we already had a biological signal. I would say the only thing that looked promising was that the non-DCD recipients had less DGF, but it was underpowered. And I don't know if that would make a difference in the long run. So if we were to redesign a focus trial, I might take the DCDs out.
Would you consider giving another dose at 6 or 12 months from transplant?
I would not. I think this is a pretty scary result, and so I would worry that giving more would make it worse. So I think we would have to see. One proposed design was to give the drug at the peri-transplant and then to keep it going for 6 months. And I'm sort of glad we didn't do that because I think we could have gotten into real trouble. There's a question here. I understand mean eGFR was similar, but are they still similar if you exclude the patients? Yeah, so the question is, if you exclude the patients with BK viremia and nephropathy, what happens to the eGFRs? And we did that analysis. That was one of the reviewers asked us to do that. And the eGFR still turned out to be not different. So it wasn't just that it had an effect. It didn't have an effect even if you took out the people who developed the kidney disease from the on BK virus? Good question.
Wonderful. Thank you so much. Thank you so much, Dr. Heeger. That was great. Appreciate your presentation.
Great. And anybody has questions, please feel free to email me.
Wonderful.
Okay.
Thank you, everybody.